testing and when do you evaluate for genetic testing in patients with cardiomyopathy, or for that matter, if you consider that as inherited arrhythmias, how do we approach such cases? So usually I like to show my presentations with the case examples. We'll do the same thing here. So these are the two cases. So one case, both are dilated cardiomyopathies, but how do they differ in their clinical presentation and what is the prognosis? So is it sufficient to diagnose that patient has just dilated cardiomyopathy and give guideline-directed medical therapy? Because that's true, both the cases needs phenotype is dilated cardiomyopathy and they need a guideline-directed therapy. This is first case for me, 42-year-old female, presented with shortness of breath, LVF of 50%, mild LV dysfunction, no comorbidities, no obesity, and you can see there is an atrial fibrillation. So it is a commonest diagnosis. We say a patient comes with atrial fibrillation, no comorbidities, we say it's a lone atrial fibrillation, right? This is first case. This is a second case, more younger patient, 26-year gentleman, recurrent palpitations, no comorbidities, and then again short paroxysmal frequent episodes of atrial fibrillation. So again this guy is diagnosed with lone atrial fibrillation, and does it matter to go further into it and will have an impact on the outcome of the patient. That's the third case, who's 20-year-old female, having diagnosed as hypertrophic cardiomyopathy, LVF of 50%, restrictive physiology, NYSE class 3, and you can see here the GLS strain also. And you can see that there is a preservation of the GLS at the apex and basal GLS is low, and we feel that it can be HCM, amyloidosis is one of the possibilities, is it sarcomeric mutation, or making diagnosis of HCM is sufficient and give the therapy for the patient. So when we have dilated cardiomyopathy, we are talking whether it's ischemic, non-ischemic. When it's non-ischemic, usually we diagnose it as idiopathic. When we know that we are talking about dengue fever and all, patient gets admitted with fever, whether it's a myocarditis, it will recover. But when you do genetic in the patients, in the unexplained cardiomyopathies, 1/3 of the patients will come positive across different trials if you go. Syndromic DCMs are more easy to diagnose. So when you talk about syndromic dilated cardiomyopathies, patient may be having sensorineural hearing loss, patient may be having myopathies, patient may be having skin diseases, Naxos syndrome, so lamin mutations or myosin mutations or SCN mutations, mitochondrial myopathies are easier to diagnose when they have a syndromic other organ involvement, but when they're present only with the cardiac involvement, it's more difficult to diagnose the cases. So what are the different classifications? We usually do the classifications as per the phenotypic presentation, right? We don't do classification as per the genotype presentations. And the phenotypic presentation is patient may have restrictive physiology, that is restrictive cardiomyopathy, patient may have dilated cardiomyopathy, hypertrophic cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy or arrhythmogenic biventricular cardiomyopathies, or LV non-compaction, which is considered as a least significant because usually they'll not have much symptoms, but it has importance, I'll show subsequently. So this is a very nice paper, came in 2014, the way we do tumor classification. They have done classification of all the dilated cardiomyopathies or all the cardiomyopathies as Moses classification, where the first word M stands for functional classification, where the patient has dilated restrictive physiology or patient is having ARVC kind of presentation. O is organ involvement along with the heart, whether it's only muscle involvement, there is electrical abnormality, that is ventricular arrhythmia is there, AV block is there, sinus node dysfunction is there, ear involvement is there, muscle involvement is there, neurological involvement is there, genetic inheritance pattern. This, when you ask detailed history for the patient and you realize whether it's a dominant, autosomal recessive, X-linked, or it is coming as a matrilineal. So that is the genetic pattern. Etiology, once you have the genetic evaluation done, or you feel that it's a myocarditis, or you feel you have done all the panels for myocarditis, or you feel it is related to autoimmune disorder. So this is how you diagnose etiology. And last is the stage of the disease. What is the stage and what is the NYJ functional class of the patient? This is how you define as a Moses classification when you have unexplained cardiomyopathies. Coming back to the first case where I showed both are dilated cardiomyopathy, and you come down here on morphological classification, both are DCMP, both has AV block. It's important. One is autosomal dominant pattern, other is autosomal recessive pattern. Autosomal dominant disease penetrance usually happens at a later stage of the age, like 20s or 30s or 40s, and the disease severity is usually lesser. Whenever there is a recessive pattern, they present with the more severe disease in early stage, and they have a worse prognosis. Always remember. So this is Emery-Dreifuss syndrome, the second one, that is embryonopathy, having a myopathy involvement also, peripheral myopathy also. Whereas laminacy mutation predominantly involve heart. They'll have DCMP. They may present with high-grade AV blocks. They may present with ventricular arrhythmias or atrial fibrillations. So that's why the diagnosing the genetic mutation, it will help you to tell the prognosis, outcome, chances of other organ involvement for the patient. So there are a lot of genes identified, like across different trials. If you go, there are more than 100 genes identified for dilated cardiomyopathy. And if you have a familial history, there is more than 50% chance you will get a positive genetic outcome. But even if you don't have a family history and you have ruled out other causes which you are aware about, if you do genetic testing, sporadic involvement can happen, new mutations can happen, and across these studies, approximately 11 to 26%, maybe 15-30% of the patients, you do get genetic involvement, and this happens usually in recessive mutations because you may have one or two genes skipped, that is one, and secondly, it's a new mutation. Third, if they have other causes of cardiomyopathy, for example, someone is alcoholic, someone is on chemotherapy, someone is having a minimal CAD, that patient's having a genetic involvement possibility is also there. You would have definitely seen patient having a CAD, having a small circ involvement, still come with the severe LV dysfunction, which doesn't fit into your coronary artery disease, right? So other comorbidities doesn't rule out the possibility of genetic cardiomyopathy. That's why asking detailed history will help, because the prognosis or outcome of the patient changes. And as I said, there is a penetration can vary. For example, someone is gene mutation positive, they'll have a normal heart by birth. But the penetration or phenotypic presentation changes depending upon which gene mutation it is. Specifically, one of the common mutation, which is laminacy mutation, your penetration increases after third decade of life. And once person is gene mutation is positive, the penetration may become very high after 40 years of age, and it will become more malignant if you have other comorbidities, acquired comorbidities, which is environmental and which is lifestyle related. It's important to diagnose genetic cardiomyopathy because the outcome differs. This is a nice paper which showed that with the patients where you have diagnosed genetic cardiomyopathies, the outcome is worse as compared to the patients who are having no genetic cardiomyopathy. And secondly, it's a clue. Any patient having a cardiomyopathy, the chances of electrical abnormality in genetic is much more as compared to non-genetic, although it's not 100%, but the chances is more. So genetic cardiomyopathies may have more electrical and muscle involvement, and again their prognosis is worse as compared to non-genetic. Having said that, I'll go back to my first case. So this is a simple 42-year-old female. She is having the no comorbidities, atrial fibrillation. We just do one, ask the family history. Let's walk through the family history. Brother had SCA at 27 years of age. Paternal grandmother died in early 20s, don't know the cause. Don't you think it's an autosomal dominant pattern? So it's not simple lone AFib. And why it is important to diagnose the underlying reason? I'll tell you, this is Moses classification, and you do genetic. Genetic says it's KCNQ1 mutation, and it says it's a short QT. And it can cause both AFib and short QT. Now let's walk through this case. You will feel that channelopathies presents with VT, right? You talk about long QT, short QT, Brugada syndrome, you talk about CPVT, but remember it will cause ventricular arrhythmia if there is a ventricular gene mutation. Imagine the same mutation is in the atrial myocardium, it will cause atrial torsades. We always talk about ventricular torsade. We underdiagnose atrial torsades. So it's well known that all channelopathy patients can present first with atrial arrhythmia, and they may not present, or they may present at a later stage with ventricular arrhythmia. This is one. Now when you talk about KCNQ1 mutation and they said it's a short QT, do you believe on this report and stop? Because it's very important. The outcome is important. Short QT, what is the treatment of choice? When you talk about channelopathies, short QT, Brugada, and idiopathic VF, the treatment is quinidine, correct? And wherever is a long QT, quinidine is completely contraindicated. It's important to go back to the patient. So this patient, if you measure the QTC of this patient, I measured it multiple times because it's atrial fibrillation. Patient's QTC is 568. So how did they make the diagnosis of short QT? Now think about it. Short QT2, so it is a missense mutation in arginine has been replaced by cysteine. They will not know whether it's a loss of function. This mutation has caused loss of function or gain of function. If it's a loss of function, it will cause long QT1. If it is a gain of function mutation, it will cause short QT2. So your person who has done analysis, he has not given the report whether this mutation has caused loss of function or gain of function. It's very important because this patient actually had a loss of function mutation of KC in Q1, and this was actually a long QT1, not the short QT2. So the correlation, whatever report they give, don't rely on that blindly. Correlate with your clinical thing, and you have to talk to them and modify the report, because now here the treatment is what? You cannot give quinidine. Quinidine will put the patient into VT storm. So here the treatment of choice for long QT1, for VT mainly it's nadolol or propranolol, but for atrial fibrillation, maxilitine is the drug of choice. That's class 1B drug to treat the atrial fibrillation. So doing the genetic analysis in this patient made a huge difference in the outcome of the patient. Coming to the second case, young boy who came with the lone atrial fibrillation kind of diagnosis. If you go to the family history, grandfather had dilated cardiomyopathy, paternal uncle had early complete heart block, was given pacemaker. Otherwise, I didn't get anything else. You do MRI, and what do you see? This is a LV non-compaction. Although we think it as a benign mutation or benign thing because it doesn't cause any symptoms, but this has association with SCN5A mutation, which causes shortening of the action potential of the atria, which can cause atrial fibrillation. So now you know the diagnosis, because you will not shell it off just like a lone atrial fibrillation, give some antiarrhythmic drug to the patient and send off. So doing the complete evaluation makes a difference in the outcome of the patient. Going down to the third case, which was having the HCM phenotype, you do genetic, and this patient has the carnitine deficiency. And once it is diagnosed, you treat with the L-carnitine this patient. You have checked for the levels, and there is an improvement in the GLS and the clinical outcome of this patient. You can see that now the GLS has improved at the bases also. So this simple therapy has made the big outcome. Otherwise, you would have given just some guideline-directed therapy thinking it's an HCM. So once you go and able to diagnose the type of HCM it helps to treat the particular patient, sometimes change the outcome of the patient. So yes, I agree. All patients, whenever you say DCMP, you go to guideline-directed medical therapy, like 4 pillars we talk about. Yes, in genetic DCMP also, these 4 pillars, diagnosing early, starting therapy early, helps to slow the progression of the disease. But we know that these patients, because of genetic mutation, we have to follow meticulously, and they will not become normal because of the genetic mutation. I've already spoken about when you compare to genetic or non-genetic, genetic cardiomyopathies have more electrical abnormalities as compared to non-genetic cardiomyopathies. Electrical abnormalities in terms of any arrhythmias, either bradyarrhythmias or tachyarrhythmias you talk about across different kinds of cardiomyopathies. So when you talk about genetic yield in the patients, you have other comorbidities also. For example, you have a hypertensive patient. You have a patient who is alcoholic. I've already spoken. You have a patient who is a CAD patient. In them, if you feel that it is not fitting, at least 1/3 of the patient across different trials may have genetic abnormality. So just keep your mind open. No harm in spending some extra time with the patient and trying to diagnose what is the genetic mutation. Last, always remember that sarcomeric mutation will not always cause HCM, or desmopathy or desmosomal mutations will not cause ARVC. So it depends upon what is the final common pathway. So it's important. For example, this is a titin mutation. It can present with HCM, it can present with RCM, it can present with both HCM and the RCM. And if there are two mutations, for example, this patient has both myosin heavy chain and lemmin mutation, the outcome is much more worse as compared to having a single mutation. Last, I would like to touch about peripartum cardiomyopathy. Across different studies, peripartum cardiomyopathy is actually overdiagnosed. If you are not able to have anything, it's always better to do genetic analysis, because if you see almost more than 50% of the patients who are diagnosed with peripartum cardiomyopathy may have genetic abnormality. So this is my take home. Like, outcome in genetic cardiomyopathy is worse than in non-genetic. Genetic analysis should be considered as a first year. If you have unexplained dilated cardiomyopathy, family segregation is very important. For example, I've done an index case. If you add in parents analysis or sibling analysis, your 30% of VUS will improve and go to pathogenic. And outcome depends upon the gene panel, and electrical phenotype along with the genetic abnormality is a clue. Thank you very much.